Thank you, Abby. Just to get an idea of who's out in the audience, is there anyone involved in health information management, clinical documentation, or coding?
I look at the documentation, and I actually look at some of the coding.
I care about it.
Yeah.
That's good.
I care about
I
it.
hear that.
Yeah, I look at it. I do case review.
Okay. Okay, well, I am taking a little bit of a different approach from the previous presentations. So the provider and the nurses are at the bedside treating the patient, trying to save their life, getting them better. And then after that is done, then they need to document. And that's where clinical documentation and coding comes in. As you probably are aware that at least this is the process at Bryan. After the patient is discharged, the chart is then picked up by our coders, and they code using ICD-10, and they assign diagnosis codes and procedural codes. And then these codes then go out the door to insurance companies like Medicare. And those codes, as they are going out the door, represent how sick that patient was that you took care of and what their risk of mortality was. So that is what I'm trying to emphasize in my presentation, that yes, your focus is on the care of the patient, but through the documentation, you need to paint a picture of how sick that patient was, because that is represented through the codes. So when a chart is coded, there's hundreds of different rules on how to go about that. And there are some specific rules as it relates to sepsis, so I'm going to focus on that. Basically, there's 3 buckets when it comes to the documentation of sepsis. And there's sepsis, severe sepsis, and septic shock, as you have heard many times throughout the day. And here at Bryan, we focus, as far as clinical documentation goes, on SIRS criteria, because that's what CMS uses. And so for sepsis, it is 2 or more SIRS that is associated with an infection, and that could be bacterial, viral, fungus. And then severe sepsis is sepsis with an associated organ dysfunction. And then septic shock is sepsis associated with hypotension that persists despite IV fluids, or a blood lactate greater than 4. So what we do here in clinical documentation, we just make sure that the treatment that they're providing that shows up in the documentation. So if we see 2 or more SIRS, and the patient's got an infection, and they're treating with antibiotics and IV fluids, and sepsis has not been documented yet, we will query the provider and ask, are you treating for sepsis? Nowadays, that's pretty rare. Our providers all know about that, and they're really good about putting that down on paper or in the computer nowadays. Severe sepsis, in order for the coders to code that, they need to see the word severe sepsis or the organ dysfunction that is related to the sepsis. So like thrombocytopenia secondary to sepsis. The coders can code that to severe sepsis. Or AKI secondary to sepsis. The coders cannot just go in the record and see, oh, this patient has an infection, they meet 2 SIRS, that's sepsis, and oh, by the way, they have a respiratory failure, that's severe sepsis. They can't do that. They need to actually look for the wording. And then septic shock. So on the other side of the screen, it's what we don't like to see in documentation, sepsis syndrome. It's poorly defined. In fact, the coders can't even code it. It means nothing in their world. Same thing with urosepsis. If it's documented in the chart, urosepsis, again, that's just not codable. If clinical documentation saw that, we would be sending a query to the provider asking, is this a UTI only, or is it sepsis secondary to a UTI? The next item is multi-organ failure. There's not a code for multi-organ failure. We need the provider to document what are the organ dysfunctions. And then sepsis with hypotension, if we see that documented in the chart, that could possibly mean severe sepsis. It could even mean septic shock. But if that's the only thing that's documented in the chart is sepsis with hypotension, it will only be coded to a patient that has sepsis. And then acute sepsis. It equates to just sepsis, but most of the times when we see that documented, the provider's talking about really severe sepsis. So then we'll query and ask them, what is your intent of the acute sepsis? Is it just a simple sepsis, or is it severe sepsis? And sometimes it's even septic shock. Any questions before I go on?
One question.
Yes.
So when you talk about that being in their documentation, is that specifically, can it be in their HPI that they've listed that, or does it have to be specifically in their diagnoses that you're using, grabbing those words, or how do you code those?
We like to see it in their H&P, their progress notes.
Anywhere within that document?
Well, that will meet. The one thing that we really don't like to see if it's just on the problem list. Mm-hmm. It needs to be documented in the plan. And there also has to be a consistency of that being documented. We don't like to see it just documented on the H&P and then not repeated again, because then we're sitting here wondering, well, was it ruled out? Is it still being treated, or was it resolved? And a lot of times we will go on and query and ask the provider that that question. Another reason why we're querying is we always talk about making our record audit proof. So if there is an auditor that comes in and looks at our documentation, we have really good, strong documentation to back it up. And it's just not a one-time, because auditors are on that if it's just documented once. Okay, the next slide is a case study that illustrates the importance of the documentation in the record. So I have example 1 and another example 2. And they're the same patient, it's just that the documentation is different. In the first example, I have a patient that has urosepsis. hypotension on pressors, CHF, respiratory distress, acute on chronic kidney disease, an elevated lactate, and elevated liver enzymes. If that is all that was documented throughout the chart, that after discharge, that patient would have a risk of mortality level of 1, which is classified as minor, a minor risk of mortality, and a 2 for severity of illness, which is a moderate severity of illness. Taking the same patient, but the provider documents differently. This patient, the documentation was sepsis due to E. coli. Secondary diagnoses were UTI, septic shock, chronic systolic heart failure, acute respiratory failure with hypoxia, AKI on CKD stage 3, lactic acidosis, and shock liver. Same patient, but the documentation looks very different. And example 2 really spells out how sick the patient was. With this patient, the risk of mortality goes up to 4, which is the highest level of risk of mortality. It's the extreme risk of mortality and an extreme severity of illness. The remaining slides deal with sequencing guidelines, and this my emphasis was to point out how important, again, the documentation is in the chart, because that's all the coders have when it comes to coding the chart. And there are many rules that are involved in coding a sepsis patient. My first example is, okay, the patient was admitted for sepsis and a localized infection. That could be pneumonia, it could be cellulitis, it could be a UTI. The sequencing rules that the coder's bound to is the first listed code is sepsis, and then the secondary diagnosis is the localized infection. The rules with severe sepsis, if a patient's admitted with both severe sepsis and then the localized infection, the first listed code on the bill is sepsis, followed by secondary diagnosis of severe sepsis without septic shock, then the localized infection, and then the associated organ dysfunction. And again, remember, coders cannot code that the patient has severe sepsis unless the provider documents severe sepsis or documents the acute organ dysfunction is secondary to sepsis. And then septic shock. If you have a patient that's being admitted with septic shock, sepsis is again the first listed diagnosis, and followed by secondary codes of severe sepsis with septic shock, then the localized infection, and then any associated organ dysfunctions. And then if sepsis develops after admission, there are specific rules on how to deal with that. In this instance, the localized infection would be listed first. And when I say listed first, I mean the principal diagnosis. Then the sepsis, severe sepsis, or septic shock, whichever applies to the admission, is listed as a secondary diagnosis. And then any associated organ dysfunctions.
Karen, what's the time frame that you would need the sepsis documentation and those symptoms to be documented so that it could be considered present on admission?
If the patient presents with SIRS on admission, but the actual diagnosis is not written or just not diagnosed until maybe a couple days later, because it takes after study the workup. If the SIRS was present on admission, then it's coded as present on admission.
Okay.
But if the SIRS was not present on admission and developed afterwards, that's when, that's how we determine that sepsis developed after admission.
So can you utilize nursing documentation for documentation of the SIRS?
Yes. Good question. So sometimes we do query our providers, because if it's not real clear whether the sepsis was present on admission or not, we do query for that. Then there's another rule of sepsis due to a device, implant, or a post-procedural infection. If this is the instance, then the first listed or principal diagnosis is going to be the complication code, or in the coding world, we call it a T code. So what I'm trying to get at this is your sepsis and your localized infection would not be principal diagnosis. It would be a complication code. For example, if you have a patient admitted with sepsis and it's due to a indwelling urinary catheter and the patient has a UTI, the first listed code is going to be a complication of an indwelling Foley catheter. And we do not assume or make any assumptions that that an infection is due to a device or implant or a post-procedural infection. That has to be documented by the provider. And so if it's not clear in the documentation, then we will query. And then my last slide is just a caveat that due to the complex nature of coding sepsis, severe sepsis, or septic shock, it sometimes requires querying the provider prior to assigning the code. Because just like treating the septic patient, it can be very complicated just to identify the patient and get the right protocol going. Same thing lies in the coding world. It's not easy to code this type of patient. Any questions? Yes.
So, it was a couple of years ago probably that I became aware of the fact that providers, as part of their physician education, they are really not educated on this documentation and coding world. And from the latest I've heard, that has changed in very, very few medical schools. So I'm just wondering, I know we've done some things internally here, especially when we did the ICD-10 conversion, but what do we have in place these days? I know you do the queries, but how do we really educate our providers so that they know which words to use for certain things? Because most of this is still dictated kinds of documentation. So what are we doing to help move that forward?
Well, our best defense is our queries, and we query a lot. You'd be surprised at the numbers. And most providers pick up on oh, I've gotten this, 2, 3, 4, 5 times, and then they learn. But sometimes we're querying the same physician or the same type of query over and over again. I know at Bryan we've brought in consultants to help educate our physicians. I know from a CDI standpoint, we have put out CDI documentation tips. So that's what we have done.
Do any of you have other things you do?
We do those things and then we see a trend with a certain query or a diagnosis that's being missed, or if we have, like right now I'm doing length of stay drill downs, and there's a couple of cases that patients stay a really long time, and it really looked like based on the coding that they should have only stayed 2 days, but when I drilled down, well, this patient was really sick, we just didn't capture the documentation. So I'm taking that to MedExec and doing examples like what you have on here, some small case studies that really gets the conversation going. So.
Something else that we just have started in the last several months is we will actually go up on the floors and talk to the doctors if our queries are not being answered or are more complex than our routine queries, and have that one face-to-face conversation with the doctor.
Do you have a time frame on how, what's your process? Do you have a time frame of how long you give the physicians to answer the queries, or before you close them out and go ahead and code, or send those off to coding, or?
We have a really good response rate to our queries, but occasionally we will have a query that just doesn't get responded to. And that's when we go upstairs and look for the provider and say, we've noticed that you haven't opened up our query, or you've read our query but you haven't responded. Is there some way I can help? And so that has helped decrease the number of unanswered queries. But yes, we kind of occasionally do have a query that is not answered on discharge. And I believe if it really impacts the DRG, the coders will follow up and try to get an answer.
Oh, before we move on, if you recall the examples that Karen had put up there, and she's been such a big help on the sepsis team, so if you don't have coders or anybody here with you, I really recommend you take those slides back and show them at your organization, because if you'll see, if the documentation can make the difference between being approved for a 2-day length of stay or a 4-day length of stay. And it's not just all about the money, it also has to do with what your mortality rates are. I mean, if your mortality rates are high, when your risk of mortality is very low and your severity of index is very low, you really need to try and align those things. It's good for your providers, it's good for your organization, and it puts money back to you so that you can put the money into taking care of patients and stuff like that. So I really think it's very, very valuable. So if the people who need to see that aren't with you today, I would recommend you take it back and show them. Yes.
Hey, Karen, our challenge sometimes is that our doctors rotate sometimes from day to day. So then if you find something on the second or third day to say, well, like this SIRS was present here, can you expand on that? And so you're querying the doctor that wasn't there that day. So they're hesitant to speak to that because they weren't the one, or if it was a surgeon, or if it was, somebody like that. And so
Right.
that's someone else's documentation. And then they are hesitant to answer the query to say, that's not really mine to speak to.
Right.
Well, it's still present, but.
Right. And we have heard that from a physician or two, and we remind him that he is the attending physician, on this day, and we appreciate if he could address the query. Most of them do. We've only had a few instances where they refuse because it's somebody else's documentation. Sometimes they will ask us to send the query to a surgeon or a specialist, and we do. But if it has to do with really a question that the attending physician should be able to answer, we hope that they will answer. As you know, if a hospitalist goes off the case, they may not be back for another week, and that holds up the whole process. Any other questions? Yes.
So how much weight is put on like the admission, like the history and physical versus the progress notes versus the discharge summary? Or is it kind of all equal? Because I have one doc, bless his heart, who everybody's septic shock.
Mm-hmm.
Just to cover himself in case he has to do that, that follow-up.
Uh-huh.
So I try to explain to him, they have to meet SIRS criteria first, then you can call it septic. I mean, it's more than just.
That's a good question. If part of our review in clinical documentation is looking at that, in particular with sepsis patients, that if they're calling it septic shock, that they meet the criteria. And our criteria is just screening criteria. So if their systolic blood pressure wasn't below 90 for 30 minutes, and they're not on pressors, or they failed IV fluid therapy, we will send a confirmation query to that provider, asking him or her to add additional information to support his diagnosis or rule it out. Thank you.
Okay, before we move into our last presenters, I want to do a little bit of some thank yous and some additional introductions. Denise Motion over here has been at the organization for many, many years and very well versed in sepsis. She also helped coordinate the conference along with Candy Wild. If you will stand up, please. So, lots of information and very key in helping us get the presenters that you've heard today. I also want to thank Dana and Andrea as well from the NHA. You got to stand up too. I just think you can wave. So that Dana and Andrea helping coordinate, getting you guys together through the NHA and the HIN, making sure that we've been given this opportunity for everyone to come together. So just really wanted to thank you guys for all that and all the work that you've done.
Thank you. You did a ton. Yes, thank you, Abby, for what you did.
Right. I just got the food together, right? But it was good food. It was good. So we want to finish off the day with one last presenter. I will say that after that, we do have some time specifically set up if you have a whole table of individuals all from the same organization and you kind of want to start collaborating, or even if you have other questions for the presenters that are still here, to kind of give yourselves a jump start as to when we get back to our organization, we want to do steps 1, 2, and 3 to kind of get us started. So we do have a few minutes set aside to do that as well. So just keep that in mind. That's why we're kind of holding on to a few of our presenters here to kind of, as you guys are collaborating and talking amongst yourselves, if you have additional questions that you didn't think of originally. Okay, so our last presenter here, but definitely very not the least, we have Renee. She has been with our Bryan Medical Center for 39 years and counting. She has held a variety of positions as a staff nurse, employee health nurse, and a clinical quality analyst. Last year received a certificate from Bryan College of Healthcare Sciences in Healthcare Management, and she currently serves as our data abstractor for sepsis, stroke, and our perinatal measures. So, welcome Renee.
So now I don't have to do my aided, right? And if I get, this may be my last presentation because I get much shorter, I won't be able to peek anymore. Well, welcome everybody. I'm so glad that you're here with us at Bryan today. I'm delighted that we could share any help or information that we can, and then we also glean a lot from you, so we appreciate that greatly. I've been in organizational quality for like the last 15 years. And wanted to take a few minutes to talk to you about the basic data collection process with you. I've been abstracting the severe sepsis cases since the beginning of this project. And my advice to you all is smile. It does get better. And as you may know, much has changed. Chart abstraction and data collection in general can be a daunting process at first, but it does get easier, and you'll see how the worthwhile process is, and we're vital members of this healthcare team that is helping to drive the betterment of patient care. I firmly believe that data collection is the foundation of every project, and here we're fortunate at Bryan to have Epic as our EMR, and then coupled with IBM Watson Health Analytics. No, I do not own any stock in them. We're able to harvest a great deal of data from them, and no one knows how well you're doing or what needs to improve until you show them. First, start off with a firm goal in mind. What are we hoping to achieve as an organization? What needs to be corrected? What is the greatest concern? What do we feasibly have the ability to collect, and how will we collect it all? And it doesn't really matter what you use for a medical record, electronic in full or partial format or paper records. There's much that we can do, and make sure, of course, that your documentation is absolutely solid and be consistent, using the CMS and QNet guidelines as a reference, and keep up with all the changes, which generally change every 6 months to 1 year ahead of time. Consult the definitions in the specifications manual for National Hospital and patient quality measures, and it's always available on CMS or the QNet website. And do any of you currently use the QNet heart tool?
We used to. We just went to a data warehouse, but we used to use it for a long time.
And this is something that most of us in quality are very familiar with, the Plan, Do, Study, Act, or Plan, Do, Act, Check. Please remember that these steps can be done in any order, but you just have to have a goal in mind when you do get started. Step 1 is to plan the test or observation, including a plan for collecting data. Start with a team, gather a group of engaged individuals, and have a physician champion. I can't stress how important that is. This champion is will be the person that will talk to the other providers on the findings. Include ED, lab, pharmacy, nursing personnel, anybody that you think would be interested. Step 2, the do, try out the test on a small scale. Start small. You will find other things along the way you may want to look at further. Do you want to have a tool for collection devised? I'm sorry. And then step 3 is study. Set aside time to analyze the data and study the results. Are we having an issue with the sample? And then, are we having an issue? There we go. With getting the antibiotics to the ED, which we had at one time. We found out with pneumonia, they were not keeping the antibiotics in the emergency room. And so we found out pretty quickly when we were in a team that this needed to change. And so we started stocking the proper antibiotics and solutions in the emergency room. And this will also give you an answer to the low-hanging fruit that you may find. In other words, are your lab draws late? Would a point of care lab personnel be beneficial? Does your pharmacy need to get more involved? Does ED need to stock antibiotics or IV solutions? And you, as data collectors, need to be a part of that team and be there at those meetings. This is the CMS sepsis data collection. It just shows you the sample size. Here we have, of course, over 300 a quarter, and instead of doing the minimum of 60 cases, we've decided to do a 50% sampling so that we cover more people. Okay, what does zero look like to you? One of the most difficult points to determine with this project is what is time zero. For the severe sepsis patients, that might be any time that the patient enters the hospital. You've heard today about the many factors that are involved that must align in order for the patient to be considered severely septic, and at what time the clock starts. For your critical access facility, you may want to begin with the time that the patient hits the door, and that's what we did with pneumonia, is we used the door time, two-door time. Set your goals as to what time you want to have that lab drawn and what time you want to have the antibiotic given. If you transfer that patient to another facility, make sure that vitally important work is done, as we've heard today. Time zero is tricky, and we argue about that a lot. But that is why it's important to have clear data definitions, and your team will need to come up with a consensus on what time zero looks like, or start time. And this is an evaluation of severe sepsis screening tool that I found on the internet. It took me about 10 whole seconds to find it. So there's 1,000 of them out there. It's a very simple little sheet. This one I see does become part of the permanent patient record. Up at the top it talks about chart record, use patient label. It would not have to. I know in electronic world that gets tough when you have to send them down to get scanned and things like that. So you could just use this as a tool, and then it could be returned to your team for study. It would not have to be part of the chart. Of course, you'd want to, make sure you adhere to this, your set of privacy documentation and not reveal any HIPAA. But you could use this as a helpful tool for nurses too. And then reporting out your results to your leadership, kind of just to reiterate, you need to start with a goal, determine what tools and resources are available to help you achieve that goal. The cyclical process of plan, do, study, and act process can be completed over and over based upon findings and goals set by the organization. Identify the population, clear data definitions for the data, the tools that are available to standardize the process and change, and report your findings and accomplishments to leadership. Scott Frost has a saying that he has no fear of failure. So don't be afraid to find the things that you do wrong or identify the things that you could do better. That's where you're able to begin your improvements. We grow by measuring ourselves. You may start with a goal, and it may require several actionable items to be implemented before the goal is met. Once the goal is met, a new goal may be defined or new parameters set. Depending on what committees or boards meet at your facilities, you'll need to report your findings in whatever format you choose. We use a standard format of graphs and grids, or we call them dashboards sometimes, and we call them the stoplight graphs, or the red, green, yellow grids. 100% compliance is green, 99 to 94% is yellow, and less than 94% is red. The sepsis indicators are reported on that. And then concurrent review. When I was the pneumonia project coordinator, or pneumonia nag, as the ED doctors refer to it, the most valuable tool we used was concurrent review, and I really enjoyed this, and we do this with our stroke project today. I would run a daily list of all patients admitted overnight, and I would look at everybody that either came in with pneumonia, heart failure, shortness of breath, COPD, anything that was vaguely related, And then if these patients were diagnosed with pneumonia, I immediately began a brief collection of the top data indicator points so that I could see what was going on in closer to real time than, it wasn't immediately, but it was closer to real time than what our abstraction is. And we were able to use our IBM Watson tool for concurrent reviews, and that worked out really well. But you can also do it in an Excel file. It's very easy, and that's what we use for our stroke patients. It's a great way to identify immediate needs and concerns. And then no one is perfect. It has taken us a long time to get where we are today. We started with about an 18% compliance, and today we're at a 55% compliance per month. The state benchmark is 50%, national is 57%, and the top 10 achievers are at 79%. Patients that are transferred into us from critical access hospitals are excluded by CMS, but not by our care. So as you can see, it has to be a concerted effort from all personnel to achieve the right care at the right time for all patients. If there's anything I can do to help, I'd be glad to, and I can give you my card when we're finished. So thank you very much. I appreciate it very much.